Dear friends and colleagues from the neurology and epilepsy fraternity in different parts of the world, especially Asia-Oceania region, I extend a very warm welcome to you. I can say good evening from New Delhi, India, good afternoon for friends from Europe, and good morning from other parts of the country of the world. Today we are in third webinar of Asia-Oceania Epilepsy Congress, which was held in February 2025 at New Delhi. This is a very interesting webinar. Earlier two had been very successful, and this is overcoming access to epilepsy care with new technologies. Or better terminology for this is that epilepsy care in the digital age, in the age of social media, electronic media. Beauty of this webinar is, though this was recorded in New Delhi, when speakers were delivering talk in person, in addition to recorded, the speakers and chairpersons now are present in the webinar in person and all set to give responses to your questions, queries, and doubts. So I welcome the chairpersons to carry on with the webinar and wish all the great success for this session. Thank you.
Thank you, Manmohan, for your introduction to the webinar. My name is Udaya Seneviratne. I'm one of the epileptologists from Melbourne, Australia. I'm chairing this session with Professor Bindu Menon. So it's my great pleasure to introduce the first speaker. But before that, very quickly, I want to tell you about the Q&A. So during each talk, you can add your questions to the Q&A box, and there will be a live discussion at the end of each presentation. So just to remind you to keep adding your questions. So let's start the session with the first speaker. It's my great pleasure to introduce Dr. Michael Fong, who is a neurologist and epileptologist with a special interest in critical care EEG at Westmead Comprehensive Epilepsy Centre and the Children's Hospital at Westmead, Sydney, Australia. Dr. Fong is a clinical lecturer at the University of Sydney and assistant professor adjunct at the Yale School of Medicine. He's a co-author of the ACNS Critical Care EEG Terminology, as well as Hirschenbrenner's Atlas of EEG in Critical Care. Over to you, Michael.
Maybe I'll start off by saying most of my research, as you can see, is in the field of critical care EEG, and I am co-chairing the session coming up on critical care EEG in the next session. I was filling a gap for this talk, and my name's probably not in the program, so I hope you're not too disappointed to hear from me. I was asked to fill the gap of discussing the future of digital technology in epilepsy care, and can we do better? That was the title. And I'm going to sort of change tack a little bit, because we've heard from a beautiful set of three speakers of how digital technologies are being incorporated at a patient level, and how those technologies can affect people, single individuals. But I was going to change tack and reassess things more at a systematic level. So I'm going to start with identifying what some of the problems are, just briefly, and then identifying sort of areas where digital technology can improve epilepsy care in general. This talk is relatively short, and so most of this comes down to discussion of concepts as opposed to some of the particulars. This is the problem. I had the privilege of being involved in some of this work, and I'm using this purely as an example. We did a survey of stereo EEG centers across Southeast Asia and Oceania. Many of the co-authors are present in this room. And the problem is that it was an estimated 573 million people live in a country with no access to stereo EEG. If you take the United States, they have one level 4, what is termed a National Association of Epilepsy Centers, National Accreditation of Epilepsy Centers, which essentially means a center that can provide stereo EEG or intracranial EEG. They have one per 1.67 million people. If you take the ASEAN countries, that number is 1 per 167 million people, which means that in order for us to meet the World Health Organization IGAP initiatives, we would have to not increase our services by 2-fold, 10-fold. We would have to increase our services by 100-fold to achieve equity. This is one example, and you can see that our numbers in terms of EEG has stagnated over the years. But there are many examples across our region as to our ability to provide epilepsy care for the populations at home. So I take you through this journey. Which is based on a graphic from an excellent review, and it's mostly about assessing what a patient's sense of control is over their epilepsy. You can see that as a person is first diagnosed with the first seizure, their sense of control drops drastically. There's a great sort of shift in uncertainty and worry about what is coming next. That does get better with some supports, but as we shift towards failure of anti-seizure medications and the possibility of epilepsy surgery, then it also introduces additional levels of uncertainty. And I'm going to argue that it's levels of uncertainty for patients, but it's also levels of uncertainty for practitioners. And we'll go through how we can improve some of these things with digital technologies. I'm going to focus on a few of the points within this graphic, and the first is the first seizure. Everyone in this room will be familiar with that a third of patients referred to an epilepsy center actually do not have epilepsy. The prevalence of psychogenic seizures is relatively high, and the mean diagnostic delay in cohorts is 3.2 years. That means that these people are having real difficulties getting into quaternary epilepsy centers, and many of them actually do not need to be in quaternary epilepsy centers. Is there the possibility that AI or machine learning algorithms can help us streamline that structure? And the answer is, of course it can. The study has not been specifically done, but it is argued that some of the AI learning algorithms can be superior to the current level of standard care. And if you think about this, I put this data in here, which is done by the excellent now Professor Seneviratne, who demonstrated that the ability of various training levels to actually accurately identify seizure. And you can see that the sensitivities and specificities for medical students, junior doctors, and unfortunately internal medicine trainees, up until the point where you're halfway through neurology training, is poor. So if you think about the number of people that present to emergency departments and things, the people that they're actually, or the practitioners that they're actually being exposed to, have very little, unfortunately, diagnostic accuracy enabled to be to actually diagnose seizure. To make matters worse, now in the digital technologies, we're often shown videos of seizures or not seizures, and many of those people have never seen an epileptic seizure in their life. Compare this to big data. Can you use a naturalistic language model where patients enter in their own description of seizures, and it gives you a relatively good idea of whether it is a seizure or not? The answer is possibly. The other component is that you can use video recordings now, and this is work from the Nelly framework, where they compared a non-fiducial based fixed video monitoring system compared to gold standard video EEG. And it was whether the Nelly system could detect whether, or accurately categorize whether patients had various seizure types. And you can see that as with any pattern recognition, that certain patterns are easier to recognize than others. And so convulsive seizures are pretty easy to recognize. Perhaps tonic seizures, not so much. But psychogenic seizure, the automated systems have a almost perfect ability to recognize those, compared to gold standard video EEG. So if we're coming back to this diagram, it is possible that we can use automated systems at this first seizure state using either naturalistic language models or video data, and several groups are working on actually using video data from mobile phone video data to categorize people more effectively into appropriate care pathways. The second component is that can we improve the actual care of those people that we diagnose with epilepsy? And it has been mentioned already that Professor Kwan, led by Professor Kwan, who I saw here at this conference, is starting off with this personal trial, which, and I apologize, this graphic is relatively small. It's taking people who receive a diagnosis of epilepsy and randomizing them to have the conventional position where the practitioner chooses anti-seizure medicine versus the novel position where the practitioner chooses anti-seizure medication in conjunction with AI assistant. And using big sort of data models in order to try to identify which patients would respond to certain anti-seizure medicines or have particular side effects of certain anti-seizure medicines, and comparing the outcomes. So those studies are in place. How about minimizing delays to epilepsy referral? This is the one that many people will quote as being a significant bottleneck to appropriate care. One of the real humbling positions is cohorts like this Swedish cohort, where 156 patients with a clearly identifiable LIET or low-grade epilepsy-associated tumor, all with epilepsy. The mean pre-surgical delay for adults was 13 years before they had epilepsy resection. And 77% of that cohort was seizure-free for at least 2 years. So that means someone, mean adult, would wait 13 years to become seizure-free when they could have become seizure-free at 1 year. And so how do we extract these patients? Everyone knows that that is a significant delay. Everyone is always encouraging referrals to, appropriate referrals to epilepsy centers. But can we help our general neurology or other colleagues in that endeavor? The answer is based on health records. This has been done. So this is an example of 14 pediatric outpatient clinics with lots of children. And it's used naturalistic language models in order to generate alerts. So to identify which patients would be better candidates for epilepsy surgery, and either providing an email alert or an electronic health record alert to that practitioner, and saying that perhaps it is a reasonable idea to refer. This is a randomized trial, so if you did not get any alert, 0 people got surgery. And if you got any alert, some people got surgery. Is that definitely statistically significant? In a greater systematic fashion, the numbers are still small, but it is promising to say that if you are getting alerts based on the system, that perhaps that will shift from either being passively waiting for referrals to us actively searching for them. And then, of course, we're sort of coming to the end of this, where we enter this great uncertainty of epilepsy surgery. One of the great uncertainties of epilepsy surgery is that we don't know what's going to happen necessarily when we do an operation. We base most of this on experience, But can we do better than that in a resource-limited setting? Can we select patients who would be the ideal candidates for epilepsy surgery? I put up this as an example of excellent work that has identified pre-surgical nodes within temporal lobe epilepsy compared to post-surgical nodes based on the MRI. And it is not unsurprising to many that if you adequately removed all the affected nodes with the resection, then you did better. This goes further in terms of being able to then provide the relative proportion of effect of all of the various pre-surgical and post-surgical features. One of the difficulties of this, of course, is that most of the features that provide the greatest amount of surgical prediction are actually post-surgical features. And so many groups are shifting towards, can we do better at using the EEG plus imaging to make some sort of characterization on determining surgical success. I'm finishing off here by saying we have many sort of, I'm finishing off here by saying we started off with this category. This is the conventional category of things or system where people have great amount of uncertainty whether they have seizures or not. We have great amount of uncertainty whether we are going to succeed with anti-seizure medication, whether we should refer to epilepsy surgery programs, or whether we're going to do well with epilepsy surgery or not. And so I'm arguing that with the application of digital technologies on a systematic level, the narrative of this changes. We go from an epilepsy journey, which is a journey into the unknown, to an epilepsy journey, which is a series of calculations at each various point, the various probabilities of success or failure, and by doing so, improving the efficiencies of the system. I'll finish off with this work, which I had the privilege to be a part of, and it is also understanding that there are many non-seizure related outcomes to epilepsy surgery plus epilepsy care. Again, identifying which of the particular individuals will do better with targeted interventions is all about selection and having some idea of which features will provide the greatest amount of ability to intervene will again come down to big data models. So the summary from my perspective as to how digital technologies will improve epilepsy care in general. We've heard many things about the personal level, but I would just say that some of the greatest impacts on epilepsy care will come down to improving efficiencies at a system level. And given the disparities that we as a region focus, it is important to have some idea that embracing these technologies will greatly assist us in that endeavor. The tools are being rapidly developed, as have been discussed by my co-chairs. And it really is, on a system level anyway, about allowing greater access to appropriate levels of care in resource-limited settings. So I finish on that, and I just thank my team at Westmead Hospital, but also my collaborators at Yale. So thanks so much.
Thanks, Michael, for the wonderful talk and giving us some insights about what we can expect in the future in this field. In the meantime, I encourage everyone to add your questions to the Q&A box. But in the meantime, maybe I'll kick off the questions by asking you a slightly provocative question. You mentioned about using AI at different levels to overcome some of the problems we have. I guess one of the challenges in using AI is we need large data sets to train these models. Now, if we look at individual institution levels, particularly for highly specialized tests such as stereo EEG, we may not have big enough data set. So looking at the country level and also the regional level, how can we overcome that problem? What are your thoughts?
Yeah, so that'll be incorporating things into the system and having everyone within that system have an attitude or keenness to participate. So I've been involved in levels in various settings. One of those being the SparkNet critical care EEG consortium data that's led by Brandon Westover. So that's, you know, tens of thousands of EEGs, critical care EEGs that have been put into these AI sort of algorithms led by Dr. Jing. And so that only comes about because we have lots of centers, that's a North American study, lots of centers who are willing to participate in their data and contribute their sort of EEG data towards a bigger cause. On the other levels, so for example, if you're thinking about, so that's the EEG level, if you're thinking about, let's say, the actual like histories, like naturalistic language models type level, that also comes down to systems. So within Sydney and New South Wales, Australia, the state is shifting towards universal electronic health record across the state. And that allows us to then be able to interrogate these large populations as opposed to a clinic level or a hospital level. It gives us the ability to do this on a state level, and if other states do become involved, you know, potentially on a country level. So you're right, it is all about big data, and big data comes down to allowing systems to incorporate with each other and share information, you know, across those in order to generate these models.
Yeah, thanks, Michael. I think excellent point. I think we have to work together as a community because this is a huge challenge. I think we all have to stand together, collect data, and collaborate for us to succeed.
And I think one of the things that came about, you know, at AOEC in particular is that, you know, the Southeast Asian data, you know, the Indian data, they're all unique in their cultural aspects and language aspects. You know, it's so diverse. And so I think the, you know, skepticism from some is that, for example, if Australia developed a model, it would not be universally applicable to everywhere, because the same thing applies with the EEG data. You know, what is the gold standard for the AI model for the EEG data? It's the EEG readers, the experts that we're putting in our gold standard numbers, right? So, you know, the outcomes and the actual markers of success within an epilepsy surgery program will differ from region to region. And how do you then get a tool or application that is applicable for your region or your center? Unfortunately, you're going to provide your data and you know, contribute to the cause, and it's by that means then you'd be able to have these models, you know, provide pretty good care across a broad range of populations.
Absolutely. Excellent point. Any other questions from the audience? We haven't got any other questions in the Q&A box.
I can ask Michael that just a quick one, that how do you think that these digital tools which we are having now, how do we balance the innovation? We can see that it's moving high and mighty. How do we balance the ethical concerns and the innovation? What's happening now?
I think clinicians will always be at the forefront of balancing you know, those components. We know the same when we provide a tool to the engineers. You know, the engineers don't have the same level of ethical consideration, not speaking ill of the engineers or the administrators, for example. And AI should be seen as something that is not taking over clinicians. It should be seen as a tool to help clinicians in their day-to-day workflows to provide better information on a bigger data. So all of those things should be limited and practiced within clinical guidance, and the clinical guidance is provided by the clinical experts like yourself.
Thank you, Michael.
Thank you, Michael. I think in the interest of time, we probably move on to the next talk now.
Thank you, Michael. And we move on to our next talk. And we have our next speaker, Dr. Udaya Seneviratne. He's a neurologist and epileptologist at Monash Health and St. Vincent's Hospital, Melbourne, Australia. He holds an academic appointment at Monash University, Australia as an adjunct clinical professor. Dr. Udaya is going to talk on the application of digital technology in epilepsy care and integration with the traditional epilepsy care. Over to you, Dr. Udaya.
I have no disclosures. I'm going to start my talk by asking the question whether our traditional model of epilepsy care is sustainable. The reason I'm asking this question is, we live in a almost digitized world. What you see on the screen is actually digitized data. When you look at the phone, that's all digitized data. When you look at a video and listen to music, everything is digitized. All the signals we use in everyday life, they're converted to binary codes, 0 versus 1, and then processed, stored, and transmitted, and as digitized data. So, are we using enough in our practice? Have we caught up with the times? So, in epilepsy, there are digitized data, the digital technologies we use every day, but there is scope to use more. To name a few, we have telemedicine, the diagnostic is quite big, EEG imaging, and then we have wearable devices, mobile apps, artificial intelligence and machine learning. There was a separate session on that in this conference. There is electronic medical records, there's the big data and data analytics. So the whole range of digital technologies are available to us. But are we using them enough? Now, if you look at the traditional epilepsy care, we have a very stereotypic model we all use in day-to-day practice. We see the patient face-to-face in the clinic or on the ward. We take a history, we do an examination, and then we order some investigations. Then we confirm the diagnosis, start on some treatment, start on anti-seizure medications. Some of them respond, some of them don't. Those people who are refractory, we look at the options of surgery, neuromodulation, ketogenic diet, clinical trials, and so on. Then we monitor their treatment. We follow them up in the clinic, take a history, look at their seizure diaries, talk to carers and families and get some information. We also provide them with some self-management advice. We educate them, we provide psychosocial support, and we look at the medication compliance. But in this very simplistic model, can we make it better by incorporating digital technology? So at every level, at every step, there is scope to incorporate these digital technologies to make it better. For example, in the first stage, the history and examination, we have telemedicine. You may still remember during the COVID-19 pandemic, this was an absolute lifesaver. We were able to continue providing care thanks to telemedicine. We still use it. Particularly in Australia, there are regional and remote areas. There are communities have to travel, several hours or even fly to see a doctor. So telemedicine is an absolute lifesaver for them. When it comes to investigations, digital technologies are quite big. We use EEG and imaging. There's a lot of scope to analyze this data using digital technologies. Artificial intelligence is quite big there with machine learning. We use this for better utilization of these investigations. And when it comes to treatment and using surgery, traditional model, we make the decision. The epileptologist and the team will discuss and choose the right drug and choose the patient for surgery. But in the digitized world, there is option for machine learning. In fact, there is a trial currently going on in Australia, led by Professor Patrick Kwan, randomizing early diagnosed epilepsy to decide the medication by the epileptologist versus machine learning. So there is scope here. There's also research published on using machine learning to select the right surgical candidate. When it comes to monitoring treatment, wearable devices are quite useful. You know that patients tend to underreport seizures. In fact, around 50% of seizures are underreported or undernoticed. So now wearable devices give us an option to monitor them better. They give more objective data. And particularly ambulatory EEGs are useful here, again, to capture and objectively measure the seizures. And there are apps, data analytics, and artificial intelligence applications there. And when it comes to self-management, once again, the wearable devices are very useful. Patients can log in their seizure diaries, and they can identify the seizure triggers. And one of the other areas which is developing and almost becoming available is seizure forecasting. So there's a lot here, but I'm going to talk about three particular aspects: ambulatory EEGs, wearable devices, and seizure forecasting. Now, in the traditional model, we use video EEG monitoring in the hospital. But with the application of technology, we can convert the patient's own home environment to an epilepsy monitoring unit. So that's using ambulatory outpatient video EEG. So it's already established and being widely used everywhere. So what happens is the patient, you set up the patient and use this device, or use this setup with the trolley bag, with the video camera mounted on it, with the Bluetooth connectivity. Patient goes home, can carry on with day-to-day activities, and with the device captures the data, including the video, and it's uploaded onto the cloud, which can be real-time downloaded by an EEG technologist, reviewed and processed, and the EEG reader can read that. So there's real-time monitoring. So this is only feasible by the application of digital technology. And what are the advantages? I think the main thing is improved access. As you know, it's very well known to you, hospital beds are very difficult and are limited everywhere, right? So even to get the patient into your epilepsy monitoring unit, there's always a struggle. Now, there are long waiting lists, and the resources are limited. So if you can convert the patient's own environment to epilepsy monitoring unit, that is much more accessible to patients. It's more convenient. Patients prefer to spend time in their own environment rather than on a hospital bed. And it allows the luxury of real-time monitoring. And the second advantage is the cost. The cost is much lower because you are using less resources. You are using less hospital resources. And third point is improved diagnostic accuracy. You see, because we are monitoring the patient in the usual environment, we are more likely to capture natural seizure patterns. I'm sure you have this experience, patients who are having lots of seizures, you bring them in for video EEG monitoring to your epilepsy monitoring unit, and nothing happens. You withdraw medications, you sleep deprived, but still no seizures. That can happen. But if you monitor them in their environment, you are more likely to capture those events. In this particular study here by Fox et al., they looked at this question. So they they looked at patients who had negative studies after video EEG monitoring. That was normal, no events were captured. Then they connected the patient for ambulatory EEG for 72 hours, and almost 50% of them yielded diagnostic information. We also looked at this question by analyzing a large database of prolonged ambulatory video EEG monitoring, and 85% of the time the question was answered. We got enough data to answer the question asked by the clinician. So it's a useful test, and the diagnostic accuracy is quite good. Of course, there are limitations. As you know, it is not safe to wean off medication because there's no supervision. You can't do retrospect. There is no testing by trained observers, although you can reasonably well train the carers and the families to do some testing. So for this reason, it's not ideal for pre-surgical planning. And the other problem with even inpatient or outpatient ambulatory monitoring is the duration. You can't monitor them forever. You know, you can go on for 1 week, maybe 2 weeks. After that, the patients get fed up, the skin irritation and the signal quality drops. So it's a problem when you can't monitor for very long. So that brings me to the next step, continuous monitoring. So some patients have very infrequent events, so it makes sense if you can monitor them for a long time. This is not possible with surface EEG. So you have to think about implanted devices. There are a couple of such devices currently being used and published in the literature. In Australia, we have just concluded a clinical trial using an implantable continuous EEG monitoring device called UMPIRE study. It looks like this. There's an implantable telemetry unit, which is implanted in the subscalp. There are 4 electrodes. From the outside, it looks like this. This little unit captures the data and transmit it to the mobile phone via Bluetooth connection, which can then be downloaded and processed. And we have seen very good signals from cortical and subcortical structures, including sleep rhythms. So these devices have many potential future applications, particularly diagnostic, as I mentioned. When the seizure frequencies are low, you can monitor them for months. In the trial, we monitored them for 6 months, so we can capture infrequent seizures, useful for monitoring therapy. It's useful to understand seizure rhythms and optimize therapy. Seizure forecasting, I'll come back to that later. And it's useful to identify and correlate with seizure triggers, and also clinical trials. So one of the problems we encounter in clinical trials, we monitor the patients for a short time, and we depend on seizure diaries, which are notoriously unreliable. If you can use these devices for prolonged monitoring and get more objective data, and we will be able to get more reliable results, because there's always a natural variability in seizures. So if you look at the seizure diary during a time the patient naturally has lower number of seizures, you might be misinterpreting the results. That brings me to the next one, wearable devices. There are a whole range of wearable devices. These little gizmos look like scenes from a James Bond movie, starting from smartwatches to little patches and devices worn on your spectacles. Now, these devices capture multiple physiologic signals, ranging from the heart rate to muscle contraction and audio, and sometimes EEG as well. And these signals can once again be transmitted to a mobile phone via Bluetooth connection. And the main application is tonic-clonic seizure detection. The sensitivity overall is around 91%, which is quite good. However, there is a small price to pay. There are false alarms. And the whole idea is capturing these tonic-clonic seizures so you can take action, particularly relevant in terms of prevention of SUDEP. And we can also collect some physiological data. With the wearable devices, the next thing I'm going to talk about quickly is seizure forecasting. This is not seizure prediction. You're giving forecast is you give a probability of seizure occurring over the next 24, maybe 48 hours. So forecast it's part of your life. You sit in front of the computer and watch with the forecast every day, hopefully. And what they do is they collect data from multiple sources and feed into computer models which can churn out a weather report. Now, similar thing can be done for seizures as well. You collect data from multiple sources, including wearables, mobiles, clinic, physiological data, analyze them, and then it gives you a probability of a seizure occurring over the next 24 hours. You can imagine how useful that to the patient, because for the patients, one of the biggest problems is the uncertainty. They don't know when the next seizure is going to happen, which creates a lot of anxiety. If you know there is a higher probability of a seizure over the next 24 hours, they can plan their life. They might stay home, they won't drive, might even take some benzodiazepine. So this is going to revolutionize the way they live and how they think. So to summarize, I think the application of digital technology is rapidly changing the landscape of epilepsy management. It helps us understand epilepsy better and achieve better patient outcomes. Traditional care model is no longer sustainable because patients are demanding more and we deserve to give them more. So what we thought as future is already happening because this is rapidly changing and the devices and the applications I mentioned are already in clinical practice. So it's fair to say the future is already here. Thank you.
Thank you so much, Udaya, for that wonderful talk, taking us through how probably the future is also going to be and how better we are placed with the AI tools. There's a couple of questions there in the chat box, if it's visible to you. And there are also concerns regarding as to how a neurologist's role is probably in the future going to be restricted only by entering the data, and the AI is going to sort of tame us around and tell us what's going to happen. And it looks threatening to some people out there. What are your takes on that? What is a neurologist's role in the future if AI is going to do everything?
Yeah, it's a very honest question. I think it's from Dr. Ines Al-Said. Yeah, I think the question is, don't you think that by time our role as neurologists will be restricted to entering data? I'm feeling threatened by this all this technology. Yeah, I think that's a very fair question. And as not only I think a lot of people have that kind of apprehension, whether AI is going to take over us like we see in movies. But I think the way to look at it, the AI is not your master. It's going to be your servant. It's a tool. It's just another tool. For AI to function, we still need the expert humans. For an example, to train various models, like to generate algorithms, you need data sets. These are data sets from humans, marked by human experts. So really, AI depends initially on those data sets for training. Obviously, then the AI starts analyzing data on its own. But I think still the human component is essential. Even after AI generates the results, to contact the patient, liaise with the patient and deliver care, there is a need for a neurologist and epileptologist. So I think I'm pretty confident these techniques are going to be tools, your servants, and not your master. I think we don't need to have any fears about that, but we should know how to use it efficiently and more effectively for the benefit of our patients.
Absolutely. As it advances, the need for the human being to appropriately use the technology will also advance, because the advancement is either ways. Yeah. There's Dr. Rajesh Pandita. He is from India, and he states that in many parts of the country, epilepsy is still seen as a curse. Or a profession rather than as a medical condition position. Then he wants to know that how can teleneurology, AI-based seizure tracking and mobile diagnostics, and also how can the caregivers benefit out of this immense technology platform where they are having so much of emotional and logistic challenges. Either ways, the patients and the caregivers in a setting like India, how can this be leveraged for the benefit?
Yeah, I think it's an excellent question, because this issue is not only in India. I think it's a widespread problem. Stigma attached to epilepsy is everywhere, and also misunderstanding, misconceptions about seizures, and that's highly prevalent. So how can we overcome this? I think the first thing is education, educating the community, educating people, patients, everyone alike. Can we use digital technology? I think that we have a very good, tool using television, social media platforms and things like that are very helpful in educating people. I think, particularly social media often used sometimes used not used in the right direction. I think this is one way you can use it efficiently for the benefit of the society. So I think we can use digital tools to improve education, and for the patients, and also general community. um, um, Bindu, I don't know, you might be having some more experience, about these programs in India.
Yeah. As you rightly said, and the question is extremely valid, because we need to use the technology to the areas, the under-resourced areas where it is highly needed, and that starts from the awareness. One could always use all the social media platforms. Apart from that, because the mobile use in the country is very high, and the internet facilities are also extremely good. One can always use the apps and other platforms to send and communicate with the patients and the caregivers. And as you mentioned, all of those devices which the patients and the caregivers can probably use and see that whether it can be put to the best benefit. Only thing is that they need to be aware that such devices are available. And then definitely logistics is a concern, and cost is a concern in a country. So probably if more and more are made, and I would say in the country, if they are devised, then that would meet the demands as well. I suppose there are no more other questions in the chat. Udaya, I suppose we could move on to the next talk, please.
Yeah, thanks to everyone who asked the questions. I think we will move on to the next talk, which is to be delivered by my co-chair, Professor Bindu Menon. It's my great pleasure to introduce Bindu. She's the head of the department at the head of neurology at Apollo Hospitals, Nellore, India. She's the Secretary General of the Indian Epilepsy Association and a board member, Genesis member, research committee member of the World Stroke Association. Over to you, Bindu.
So from there, what Udaya has spoken about how devices are being used more and more in our clinical practice, I would look into the aspect as that when we start using them, where we should be careful, and what can be the repercussions of certain times, and there could be some remedies as well. So we are moving from, has been beautifully put in by Dr. There's from traditional approach to what we can call it as a technotherapeutic approach. So from face-to-face, it's telemedicine, patient-facing lectures, and support groups and paper-based instructional materials. We can have wearable devices, mobile apps with all the instructions, and an ambulatory EEG as well. But then definitely there are a lot of challenges while we are moving, and the speed is too much that we are not even realizing that there can be some repercussions while we are moving so fast.
So what are they? So I've tried to put some of them there, and some challenges and some solutions as to how we can move about it. First is the data privacy and security. As we all know, that becomes a very important aspect, because more and more information is being passed on. More and more information is on the cloud. More and more information is on everybody's app. Then there's a digital divide in accessibility. We are not sure how much the rural population, as we stand in India, we know that around 60 to 70% is rural population, how much they would be equipped to move with the speed that we are having with all of these devices. So, and accessibility as well for them. Obviously, there are a lot of regulatory and legal hurdles when we have all of these things where their data sharing is at the utmost of any of these apps and wearable devices. There is a lot of information which was there already in our healthcare system, and how do we integrate those with the ones which we already are going to have the patient to put on? So we need to put both of them together. And then there is a user engagement and adherence. Now we know that the human attention is only a couple of minutes, and we can really not ask the person to keep engaged with any of them and to comply with what the doctor asks. Either it could be a device or it could be a mobile app of any of those. So let us take the data privacy and security, and that's one of the most important things, because as we ourselves have created an epilepsy help app, that is EPILEPSY HELP, that is a free app, and we know that how much we struggle to get in and to maintain it on the Play Store. So there is a sensitive health and data exposure. So a lot of patients, the patient logs in, patient's details are there, patient's locations are there. The patient has a seizure, then the patient's location is shared. So all of these data are there, which are sensitive health data, which can be shared to another third party. There are cyber attacks on unauthorized access. We all of us know that there are some phishings, and we all of us at some point of time, we click on a link and then we find that there are certain things happening. And at this point of time where I talk, we know that it is at the higher most. The cyber attacks are the higher most in any part of the world. Then there is a third part of data sharing and risk. Yes, many of the researchers might logistically tune with all of these partners and try to take in data of the epilepsy patients. The pharma companies might try to take in data from these patients as to know that what is the medication culture that is being followed in a particular area. So all of these data, third-party data sharing and sharing risks will be very high. And obviously compliance with the global data protection laws. So we in 2023 have the Digital Personal Data Protection Act in India. So this is the app which, just to give a hang of how we went through, this is the app, this is freely available in the Epilepsy Help Play Store. And this is available in 3 languages, English, Hindi, and the language that we speak in our place, that is Telugu. And all of those variables was okay with the Play Store, but then there's another alert there, because if the patient has an aura, the patient can already feed in a number there, and if the patient feeds in the number, and that icon will come on the desktop. So when the patient gets an aura the next time, the patient can just click on it, the patient's location, as well as I'm going to get a seizure message, as well as a ring will go to the particular number that the patient has fed in. So this is just to give a patient a sense of empowerment, that he is safe, he doesn't need to worry. But then we have had difficulties. Rest always okay, but this was a secure app which we had made. No data sharing with the primary consultant or anybody, except for the person and the number that the patient himself chooses to share, so that the patient can be located while the patient is having a seizure. But then we keep getting these mails every 3 to 6 months from the Google Play Store that you have to remove the read image methods, or there is Google couldn't verify your identity, because they feel that there is a sharing that's going on. There is a sharing of the data, but it's just a location sharing, but then it goes to that there is something called a sharing going, and it keeps coming off and on. We have every time been able to keep it back, so it's still available. If somebody is interested and wants to share it with their patients, it's still available. The second is an enhanced cybersecurity measures. So how do we go about it? The sensitive health issues We have encryption and secure data storage. We can blockchain for the secure health, multi-factor authentication methods are there. So all of us know that anything and anywhere where we go, there's an OTP, one-time password that we always get. But then is that one-time password only sufficient? Because nowadays it's really difficult that to click on the OTP becomes very difficult because we don't know whether it is a genuine OTP or a OTP which is from the service provider itself. So you need to have multi-factor authentication and an AI-driven threat detection, because you need to install what we are doing with their help itself to see that the threat can be minimized. And obviously we need to go through the security audits. So any of those devices, wearables, telemedicine, so you need to have a regulatory thing in place so that once the system gets moving, we can stop it at somewhere in between. So it becomes very difficult. So for this multi-threat detection, this is an epilepsy forum, but then just to show that we have a Stroke Connect app as well, which connects the app to the public. And this is a secure app that it has a one-time password. But apart from that, we also have a code that is sent. That is a code which only I know because I have devised the app. So only in a secured forum, in a closed group, we connect the general public with the app, with the OTP, as well as with the code. So this, the Connect app is not in public. It can be secured to the particular hospitals that they want to in case the patient gets a stroke. So in that way, if at all we are devising anything, we can have not only one level of authentication, we can have number of levels, and also it can be closed groups and then move into a wider range. The second is a digital divide and accessibility. As we know that there are geographical barriers, as Dr. Udaya has mentioned, that we need to expand the telehealth for that. And that can be done in a minuscule manner, having small gadgets, having the patient sit there, that we do in our Neurology on Wheels program. We have a We Reach, We Teach, We Treat program, and for that we had the last one added, We Care. So we have our team go there, set up a system there, have the patient sit there, and let them understand that there's something called as telehealth. The next time our team might not be able to go there, having them sort of getting acquainted with the whole idea, and then they can have it on their own devices. Economic constraints, it's not in our hands, but then yes, affordable tech initiatives the government is really working on. Digital literacy, you need to familiarize them. So any of those patients who come to your outpatient clinics, you need to familiarize them with all of those wearable devices, have some small talks, tell them on and off that there are certain things which are moving out in the neurology field, which is not going to be paper, and it is going to be on the cloud, in the air, and you need to be more acquainted with that. And then obviously the policy and infrastructure support, which we probably are not directly concerned, but then obviously as part of organizational committee members, we need to put it forth to the government and have some initiations taken from there. So the last of the language and cultural barriers, the multilingual interfaces. So when anybody is devising at the international or the national level, it should be devised in such a way that it can reach to the rural areas of any other place. So it could be friendly with multilingual. So we should, like, if we have any of those levels, we can change it to our languages as well. So the regulatory and the legal hurdles, I'm not going to speak much on that because it's not in our hands, but there are standardized regulations. The most important part is that while we get into all of these telemedicines and wearable devices, how much the insurance coverages are there for them. So we need to ensure simultaneously that this is the way to go and this is the way to stay. So insurance coverages need to be incorporated into that. So integrating with the existing healthcare system is absolutely very, very difficult. There are interoperability issues, there are standard APIs and cloud integration, and there is obviously a resistance to adoption. I'm not sure where all of our healthcare professionals are okay to say that I will go by telemedicine. I want to have my patient by my side. The patient wants to be by the side of the doctor. So it takes some time to adopt it. So it is always better to have hybrid models at the beginning, have the patient initially and then switch over to telemedicine, have them intermittently come for again a face-to-face consultation. Then there are the data security risk and the cost and infrastructure barriers. The cost and infrastructure barriers are as humongous, and one needs to look into it because it's a system that needs to be in place, and also to ensure that the system which is in place would be used effectively to bear with the cost restraints. The last is the user engagement and adherence. So in apps, we have seen that there is a low app retention. So people who may download our app, but then effectively might not continue to use it. So particularly our app, which we say that we have only a retention rate of around 75%, which I feel they should be using it for 100%. It's for their illness. It's for their benefit that we have created. It's for their benefit we have devised it free of cost. And there is no one-to-one interaction. They just have to keep in their data. So this might need some gamification and rewards in that, because the app might want to talk to the patient. You have not accessed the app for a long time. Would you want to feed in your details? Did you have anything? So you would need to have an interaction from the app. There is a digital fatigue, definitely. So much more is there. It's not the patient is just wanting to see a particular app. There are accessibility barriers, synchronization with the EHRs and the wearable devices, and there is a lack of personalization. So whatever we make, we need to be personalized. You can't have a rewarded statement from the app or the wearable devices. So the AI need to identify what's happening and then give a personalized statement so that the patient gets engaged to it, and then it becomes a user-centered design. So again, this is another app which we made for the migraine care, and this app gives you a personalized statement. The patient keeps in all of this is also a free to download app in the Play Store. This gives a personalized message to the patient after the patient has kept all his demographic details and his, how much he eats, how much he takes water, how much he has exercised in the week. They gave you a statement as to how good he has been in his day-to-day and what could have been his triggers for his migraine, which he has already written. So I did take this picture from the internet, that is your MRD taking more space, and this looks really weird for me, that it's difficult for me to get in and see that patient. So isn't it better to switch from a digital MRD to a document management software? So, and then this one looks more precise, more genuine. But then having said that, what I have detailed, any of those challenges, if we tend to divert it, and a patient-centric, secure, and accessible digital ecosystem, if we have, then there's nothing more than that which a clinician can ask to give and render better care to the patient. Thank you.
Thank you, Bindu, for your wonderful talk, particularly showing us the remarkable work you have done in India using digital technology for the benefit of patients. I was going to actually ask a question about that. Was very interested and impressed about your epilepsy help app. It's so simple, but I think it's a wonderful thing because when you talk to epilepsy patients about their seizures, I think they bring up two main concerns. Number one, unpredictability. I'm worried I'm going to have a seizure, at a time, at any time. I don't know when it's going to happen. So that unpredictability. The second problem they have is, if I have a seizure, if nobody is there, am I going to, injure myself or die? Or, how can I let my family, my loved ones know that I'm going to have a seizure when I'm having an aura? How can I inform them? So I think your epilepsy help app is a wonderful invention. So tell us a little bit about that. How is the uptake? Is it widely used across India, or is it available in the rest of the region as well?
Hi, Udaya. Thanks for that. Yes, it is available all across the country. I'm not sure about outside the country, but then anyone can really feed in today and see. I've asked a couple of my friends. I'm still yet to get a feedback from them, probably. So it's a very simple app. It's a very user-friendly app. One can just put in all the demographics, put in all their data, the time of the seizures, the seizure diary itself, their upcoming consultations, their reports. They can upload their MRIs, their EEG reports. The whole graph might be difficult, but then just the first page of the report could be easily done. In case they've had a seizure and their bystander has recorded that, they can, in fact, even upload the video as well. So that becomes easier because most of the times we have patients who continue to scroll on their video in the gallery, and then they really don't get it either. They have lost it, and it's a concise. It's in one platform, so everything is there. And apart from that, as I said, we have been struggling with that alert icon there. So they can feed in a single number, and as soon, if the patient has an aura, obviously the other patients, it won't be helpful. Even if the patient has had a seizure and is in a little drowsy state, if he's able to handle it, he can still put in click on that icon, so a message and a ring goes off. But that particular icon, very frequently the Google Play Store just takes it off and says that there is communication of patient data with yet another person, which they feel that it's a privacy breach. It's being used by my patients specifically, all of the patients who come to the outpatient. But as I said, it still happens to be 75% retention because it still doesn't need anything. If you had a seizure, you just have to put in there. But I think it's a digital fatigue because there's so much there on the screen, so they forget to put it. I don't know. But outside, there are a couple of patients who are using it because I get feedbacks from them. But then it is not so very widely used in the country. But then I do plan to use it into the government platforms to see that it is incorporated if they find it good for use on a larger scale.
Yeah, I think I see it as a very useful feature, from what patients tell me, The other question I was going to ask is, kind of connected to that, can they use the app to call an ambulance or the patient or someone else to like call an emergency number, call an emergency ambulance or something like that?
Actually, the Epilepsy Help doesn't have. This is an epilepsy forum, but I have another app that is the Stroke Connect, which gets directly connected to the ambulance, gets a WhatsApp message, and also gets a mail to our emergency with all the features, the comorbidities, and the particular stroke symptoms that the patient has. This one, I haven't done that. But that's a good idea. I could always have it. Again, the privacy breach issues are there, 2 numbers. Thank you.
Very nice, sir. Excellent.
So if there are no more questions, I do not see them anything. Can we move on to the next
Yeah, I
talk?
think we'll move on to the next talk.
Okay, thank you very much. And our next speaker on this webinar is Dr. Lakshmi Narasimhan Ranganathan. He is a professor of neurology at Sri Ramachandra Medical College, Chennai, and he's the president of the Indian Academy of Neurology. He also serves as the editor of the IJEP, Journal of Stroke Medicine, and South Asian editions of De Jong, Paul Brasses, and Biller. And Dr. Lakshmi Narasimhan is going to talk on innovative application of digital technology in epilepsy care. Over to you, Dr. Lakshmi.
I apologize to all of you for there is bound to be some overlap in whatever we are talking. So we will try to our best of our efforts, we will try not to overlap. I don't have any conflict of interest. If you look at innovation in digital, the first one to come was mobile. In 2009, the mobile phones, various applications for patients, for caregivers, for healthcare professionals, therapeutic algorithms, we never knew at that time. we published in 2009, this was an Atlas Award winning article with Professor Manmohan Mahendrata. This award was chosen among all disciplines, the best article published in that particular month. About 2 lakh articles, they chose it. But I didn't understand that it was so. Then we predicted all these things. All these things have become true today in a decade. So you will all understand that it is you have to get yourself familiarized with the digital innovation, and there is no way out. The second important innovation is the robot, the bots and the robots. What does it do as far as the epilepsy care is concerned? The robots ROSA, robots stereo EEG, and the robots LIT. And this is the robotic stereotactic assistant called ROSA. And this, you can see the robot precisely localizes the lesion and helps in the lesional removal. Then robotic stereo EEG, which is even now available everywhere, it just makes in fact, there are MRI enhanced stereo EEGs where it initially screens the patient, chooses a trajectory which is devoid of blood vessels, and then puts a burrow and then puts the electrodes. This is done as a daycare procedure. The depth recording of the stereo EEG, there's a lot of talks about that in the conference, so I don't want to go into So this is where another application where the robots are playing a major role. See, SEG is very safe. The advanced imaging techniques like 3D CT and the takes, and so that no vessel wall damage is done, minimally invasive, reduces post-op infection or pain, the patient can leave on the same day. Then, as far as the ablative procedures are concerned, lot of newer advances on robotic assisted ablative procedures in epilepsy surgeries. Laser interstitial thermal therapy is called LIT. Here, MRI guided foci identification, laser probe driver, laser thermal ablation, and post-op. These are all procedures which are very short-lived. Here, the laser beam is used. The technique is a laser beam guided into the epileptogenic zone, delivers controlled thermal energy, minimally invasive, small burrow, reduced surgical risk. Patients go on the same day. It's useful in mesial temporal epilepsy, hypothalamic hematomas, research limitations, and in MRI negative cases. Advanced ablative procedures like radiofrequency thermal coagulation, used for patients who are not suitable for conventional surgery due to challenging epileptogenic focus. Again, electrodes are placed precisely inserted, targeting specific brain regions with minimal tissue removal, especially useful in focal epilepsy. Clinical outcomes are significant seizure reduction, though the risks are hemorrhage, infarction, and all. Applications very effective in hypothalamic hematomas and may be combined with other neurostimulation techniques. The last but the least is sound. This is now the application of this magnetic resonance guided focus ultrasound, MRG FUS, has become extremely common in use of, especially in the field of movement disorders for various, creating a T2 hole by non-invasive by using the sound, especially the intracranial probes. It's an outpatient procedure and the results are literally instantaneous. You will see the tremor stops instantaneously. And the applications have now become more and more wider, and this is also being used in any focal epileptogenic lesions. Again, the preoperative MRI locally locates the epileptogenic zone, high intensity ultrasound, focus ultrasound generates heat. What is happening? You have to keep a cooler bag around your head to prevent the brain from getting heated because these high probes produce a lot of heat. Non-invasive, minimally invasive alternate, and it's a well-localized seizure foci. It is very, very effective. The fourth innovation is artificial intelligence. This movie clip which I just wanted to say, it has got all the AI. It's one of the famous movie from Rajinikanth, one of the Indian heroes in the film. You can see the AI is activated and is fighting for it's a robo. So it combines all, it's a robo, it's got a virtual reality, it has got The AI stimulates the triggers. You can see this. So, even though you have AI as a weapon, is as dangerous as this. I wanted you to remember that it is. I'm always scary about the AI because we can't give sabbatical to our own brain. Our intelligence has to remain, and more it is getting. You can see our. I may not be surprised the thumb gets hypertrophied in the future humans. Yes, but and the brain starts shrinking. So I don't think that we should do that. And then, so as soon as a patient enters into the epilepsy room, the first thing they do is a scalp EEG and then they do an MRI, the structural MRI. And once that itself gives quite a lot of data. And then if most of the patient was prescribed some drugs and they recover, 70% of people recover, and the 30% who do not recover, then they go to a second phase of investigations like stereo EEG or a video EEG. Again, more and more data, and again higher functional images like PET or FDG PET or SPECT or functional MRI or task-based MRI, and then all this being stored into one electronic health record. You can imagine for one patient would have so much of data, and it is, I think, inhuman that you will be able to get any valuable information when you decode such data. You will definitely require the AI in analyzing these data. So all these data or multimodal integration of this data is going to be the future, and you have to learn about this. The fifth innovation, digital revolution in human and pharmacogenomics. As you all know, the digital technology has made its entry into genomic analysis, cell and genome therapy, transplants, drug development and diagnostic imaging, and the theranostics. The therapeutic diagnostics are also come into it. This is the greatest breakthrough of this century, the CRISPR-Cas9, the gene editing technique. You will see the non-homologous and the homologous. You can see you can do a nucleotide deletion or nucleotide addition to produce the repair, or you can even introduce a nucleotide and then produce a repair. CRISPR-Cas9, greatness to that lady who did that. She had made it as an open source. So in India, we have at least 2-3 very big level CRISPR-Cas9 labs, which Tata have invested in about 600 crores on this. And monogene disorders are going to be out in a decade. In my prediction, it will be all these monogenic disorders will be out in a decade because of this gene editing. Then viral base, you must have seen all this viral vector based, even in your vaccines, the same viral based things were there. Introduce a nuclear genome, ask the viral go into it and replicate inside the. That here you can do a transgene translocation and produce an anti-epileptogenic protein. The applications are far more many in pharmacogenomics and genetics. So gene therapy, CRISPR-Cas9, viral vectors, lot of potentials, molecular therapies, ion channels and neurotransmitter modulation, focus on drugs which can produce neuron excitability and network dynamics, targeted drug delivery systems like nano bombs, nanobots, precision medicine. So now the whole epilepsy care is moving towards precision epilepsy, tailored therapies based on individual genetic, as Bindu rightly put out, that before the entire data drowns you, you become more and personal, can connect with single person. Surgical integration challenges will overcome. Again, I close my talk with this clipping. Sound?
Pushed us into the river. I mean, metal gets pretty pliable at those speeds. She's pinned, I'm pinned, the water's coming in. I'm a cop, so.
It's a scene from one of the very famous ones.
I already know everybody.
Two of them are drowned. One is a girl, another is this cop.
Just a few more minutes before we figure it out.
A humanoid.
NS4 was passing by, saw the accident.
NS4 is a humanoid coming to the rescue.
You are in danger. You are in danger. Save her! Save the girl! Save her! It
didn't save her, but it saves the cop. She she dies, because the humanoid predicts the survival chances of the cop is more than the survival chances of.
But it didn't save me.
The robot's brain is a difference engine. It's reading vital signs. It must have calculated that.
It did. I was the logical choice. Calculated that I had a 45% chance of survival. Sarah only had an 11% chance. That was somebody's baby. 11% is more than enough.
Yes, this is what humans would have done. 11% is more than enough. We would have been far more empathetical. We would have made all efforts, and not like a humanoid which doesn't have any emotions attached to it. So even though all this AI, mobiles, robots, wearables, CRISPR-Cas9, virtual reality, and many more to come, but compassion and empathy will stay forever. Thank you very much for your attention.
Thank you very much. I suppose we do not have Dr. Lakshmi Narasimhan with us virtually on this platform at this point. If there are any further questions?
I think there's one question in the Q&A box.
So there's a question where in India, where specialist access is limited and stigma around epilepsy persists, how can AI-powered tools like seizure prediction apps, automated EEG analysis, or teleneurology platforms be scaled ethically and affordably to bridge the epilepsy care gap in rural and underserved regions? From Rajesh Pandita. And absolutely very, very important, as there's a huge urban and rural divide in the country and in many other parts of the world as well. So to answer the question, I suppose we need to be smooth sailing on this actually, and there needs to be the AI design tools should be in local languages, because there are several tools available out there if you go into the Google Play Store, but then that may not be very suitable for our country here. It should be in local languages with intuitive interfaces and with the low literacy population that we can have. We need to ensure certain offline function. You need to have a low bandwidth adaptability, It is not possible that all the apps function at the best in all the bandwidth. So you need to function the app, make and devise the app, keeping into mind where this might be used and where this might be more useful rather than being used, more useful. And obviously, in a country like India, we might have made apps, but then we hit a ceiling level, and it is important that we partner with the government health programs. We have several of them, the National Program for the Communicable Diseases, the Ayushman Bharat, and certain CSR initiatives. And in our country, we do this capacity building. We need to train the ASHA workers. We have these community health workers who are the one point of contact with the patients in the rural sector. If we make them digitally empowered, then they are the best people who are in direct communication with the public. They can probably, we can call them as a digital health navigators. They can reach into the public more so. That's my take on how as a person who is involved in the community health programs looks at it. Thank you for the question.
I think that's all questions we have for this particular talk, I think.
Thank you. Then I suppose so that we can wind up. Thank you for attending the third episode in this AOEC Webinar Series. We hope to welcome you to the next episode on 24th of June, where Helen Cross and Emilio Peruca will go head-to-head in a lively debate titled "Cannabis and its Derivatives for Epilepsy, Are the Benefits Overrated?" Thank you very much.